Hello and welcome to Healthy Living. I'm Dr. Donald Pelto, and I have Dr. Teresa Burtoft here. She is a podiatrist in Massachusetts with us. So welcome, Teresa. Thanks for joining the show.
Well, thanks for having me. I appreciate it.
You're welcome. So this is, we're going to talk about best practices within podiatry and what's really working for you right now and what you're excited about. So let's start out with something that we all see with plantar fasciitis. So tell me a little bit about what's working for you now. What are some of the changes you've been implementing?
Some of the biggest changes is that we do a lot of the EPAT for our plantar fasciitis. I still do traditional treatments, patients that come in. I do cortisone injections. I'm not afraid of doing cortisone injections for that. We do orthotics for that. Everything everybody else does, the stretches. The Equinus brace, I've started using that a little bit more, which goes up behind the knee. They can use it for an hour a day versus trying to wear it at night where they're uncomfortable. Mm-hmm. But the EPAT is really for people that are not getting better with the traditional stuff. We just move right into the EPAT after. If I give them 2 injections and they're doing all their other things, they're being reasonably good patients with doing the things we ask them to do.
Yeah.
Then we move into the EPAT. And people they just want to get better. And the EPAT, we do 5 treatments.
Okay.
And we do 5 for heel pain. And then we let them go for a month or 2. We have them back, reevaluate. And usually it takes some time, but you can see they're getting better after each treatment. So that's probably the thing that I use most for heel pain.
Perfect. There's been a lot of talk about combining that with regenerative medicine, such as PRP and Amnio. Any experience with that or any thoughts?
Yeah, I started using Interfil, which is the placental-based biologic, and I inject that. I have not needed to use EPAT on people with it. It's been successful. I'd say, again, probably 80%. My test case with that was a patient that has had plantar fasciitis for 12 years, has had everything under the sun done, right? Everything, including surgeries. And she did the Interfil and she got better. Now she's, in a boot for a couple of weeks and she actually got better with that without any more EPAT. So I think that's exciting part. I haven't really integrated the 2 as a combination as a whole, but I will do it individually for certain patients. Yeah.
Okay, perfect. Let's go on and talk about your best practices. We all deal with warts and they're very challenging. You have some new technology you're using in the traditional one. So tell me what's your typical protocol for, let's say, a single wart and then like maybe a mosaic wart.
Sure. For people that come in, adult or children alike, when they come in with a tiny small wart, I'm like everybody else. I use Canthrone. That typically works pretty good. Children they're fine with it. Adults cry like babies, right? But you let them know that up front. People that have been going after the warts for a long time, you have a pulse dye laser. The pulse dye laser is great. Yes, it is uncomfortable for people. I do block them for a lot of, if we're doing big warts, I block them and then we go to town on those warts. And the pulse dye does work, but it doesn't work in one treatment. It takes many treatments like most warts do. But the newest technology that we have is the Swift, which is the microwaving of the lesions. So we've had people that have failed and we have people that come from all over just for the Swift because they've tried everything. And I will say that it works about 80% of the time. It is not pain-free either. Okay. It is uncomfortable for patients, but I've seen some of the worst warts come from other areas now that I wasn't a believer until I did it.
Yeah.
And I was shocked by how well it worked. Now, again, I still have some people that I have to do more treatments for, but it's another
modality you have.
Bullet in my gun for these people.
Now, in terms of, I know in Massachusetts anyway, we're reimbursed pretty well for any type of lesion destruction. In the Swift, can you bill insurance for that, or do you do a separate amount, or how does that work for you?
No, you certainly cannot bill insurance for it because you're not destroying tissue. You're inciting their immune system to fight the virus, right? So, okay. And I do explain that to patients that if we do the traditional things, we can bill their insurance and we get paid pretty handsomely for that. Mm-hmm. Alternatively, when we do Swift, we actually are losing money, believe it or not, because patients are coming in once a month, right? They're coming in once a month instead of every 2 weeks. And we're getting paid, a little bit less. Yeah. So I want to have things to offer my patients. And when patients come into your office and you provide that miracle for them, if you will, when you do these things, they come in for other things and they bring other people. So you take a hit somewhere financially, but you get that back tenfold.
Yeah, I think that's a good way of explaining it. It's something, and they may search for it, and they come specifically in Massachusetts. I think you're one of the only ones that has it, and so they come to you
Correct.
for it.
Yes.
Great.
Yes. I won't be the only one for long, I don't think.
um, let's now move on. You talked about these kind of new technologies that others are doing. Do you have any new technology you're using, for example, for nail fungus, or we talked about some cosmetic things or some treatment things. What's working for you with nail fungus? That's a challenging issue.
Well, nail fungus, I mean, everyone has the fungus problem, right? So again, it's, I think, patient education, but we do our lasers on we use our pulse dye laser. It's probably not as effective as a YAG laser on nail fungus. We have that in another office. Again, I do a lot of Lamisil still. I do. But we try a combination of topicals. I use a Formula 7. I'm not a big believer in topicals by themselves unless the fungus is very minimal.
Correct.
I'm a believer in patient education. I will try the new thing coming out, the Onifix for ingrown toenails, and they did mention in their video that seems to stunt the fungus for some reason. Haven't tried that yet, but that'll be my next go-to, I think.
And then what are your thoughts? Some people recommend nail avulsion to deal with nail fungus. Do you have any percentages? And then also for the appearance, we talked a little bit about Keryflex. What are your thoughts on that for nail fungus?
Yeah, I will tell you for nail fungus, I'm not somebody who likes to avulse the toenails for that. I believe in my go-to with that is I tell people your nail bed is like a ball of dough, right? If you have that ball of dough it's confined, it's fine. But you take that lid off and that dough kind of expands, your nail bed changes and gets that bulbous appearance at the end when you do that. It takes a long time for those to grow back. And you still have to treat the fungus as it's coming back in. So I'm not a huge, unless they're completely painful for people. And if they're really painful and they want to give it a try, I'll do it. But I'll do a matrixectomy on those as well for patients who don't need a toenail anymore or want that cosmetic appearance of a toenail.
Yep. Me too. And then the Keryflex, are you finding that pretty effective in terms of appearance for nails? Any problems?
Oh, sure. I have patients.
Any problems with it?
The Keryflex does really great for people's psyche more than anything, for women that want to have a toenail and paint their toenails. I have a few guys that come in, they're going to be going to the beach and they want their toenail to look nice. We put the toenail on and they're happy as can be. The failure with that is that people, even though we educate them to come back to have them removed, if they're only a one-timer or something, they don't come back readily enough. But I have patients that come in every 6 weeks and have another one applied.
Wow. Yeah, I do it every 2 months. And I think we talked about this before, but seeing people break down. And one woman I had, she'd been 9 years, she hadn't wore sandals. And I said, have you been wearing Band-Aids when you go out? And she cried, because it's like we can read their mind, and there's certain patients that are really embarrassed, and it's something that we can offer them. Perfect.
Right. I think we all need to be a little bit more cognizant of what the embarrassment factor is for patients. We see it every day, but this is something they live with differently than we do. Yeah. And the emotion with it it's high for a lot of people.
Yeah. So any other high tech or kind of modern types of treatments you offer your patients?
Oh, we use the MLS laser as well. We use a lot of laser for musculoskeletal issues, from perineal tendonitis to neuromas to second MPJ, predislocation syndrome. Yeah. We use it for all of that stuff. And that machine is running every day, all day.
So tell me kind of what your protocols are, your effectiveness, pricing, things like that.
Yeah. So with the MLS laser, we now just purchased the new robotic one as well. And we have another one in our other office. Pricing for us, we're going to do $300 for 6 treatments. And then if they need more treatments thereafter, that's going to just be $50 as they go.
That's really reasonable. Yeah.
Yeah. I'm not somebody here to gouge people. I want people, the more the merrier in my mind. I want to really, truly help people get better. And people who can't truly afford it, I do a lot of it for free. I just do. And that's okay. The machine's going to be idle, so you might as well have somebody using it. It doesn't cost me anything to run the machine. Electricity, right?
Yeah.
And some people truly just need some help, and they can't afford things. So I think it's good to give. Other stuff with MLS, I don't do plantar fasciitis with it. I don't think it's deep enough. That's why I go to the EPAT, right? Okay. But for second MPJ, you've done a repair, they scar down a lot. Maybe if you've done a while with it, that it really does help break up scar tissue and help the healing process and reduce pain for people. It really does.
Great. It's a neat one thing. Since we're just chatting here, something that I found that's worked pretty well. Sometimes I do like a Z lengthening of the skin, or something where I know there's going to be a thicker scar. Certainly I'm using the Mederma and everything else, but I'm finding my laser, I have a Cutera, and there's a certain setting I use, and it really helps with the scarring. And I can use kind of like a lesion destruction code for that as well, and it gets covered.
Oh, that's awesome.
So
that's awesome. I'll have to get that code from you. I use the pulse dye laser for more scar tissue. This is more for, reducing some edema, and for increasing range of motion a little bit when they scar down deep. For just dorsal scars, skin scars, the pulse dye laser works nicely too.
Yeah. Let's move on and talk about some pearls. Maybe there's some younger doctors, even more experienced ones. I always like to learn how people explain orthotics, because orthotics are a challenge for patients, not just because in Massachusetts they're not covered normally. How do you explain it in terms of for patients to know? Because we can recommend it, we know it'll help them, but sometimes the explanation is hard.
Yeah, I agree. I think again, I change my spiel, if you will, depending on the patient. Sometimes it's sitting in front of me. I don't judge patients. I offer everybody if they need it, right? So I'll have patients, I carry an over-the-counter product, right, in orthotic footsteps I carry in my office. Majority of people are fine with that. The cost is low. I charge $55. At least and I tell them it's kind of a training wheel. But my spiel to get them to think about an orthotic is that, think of a foundation of a building. If your building has a crack and it's a little bit wobbly, the rest of the building is not stable as well. So if we fix your foundation, hopefully, the rest of the body will follow. And I can promise you, if you don't fix the foundation, you're still going to have that discomfort. And we, of course, talk about proper shoe gear and things like that. We also have the 3D laser orthotics now, which people like that wow factor. Looking at the program, seeing their force plate. We take laser pictures of their feet. And the orthotics, I've been fine with the orthotics. I think they're great. They're a little bit different than the traditional orthotic. And people, once they see that, they're sold. They're sold that they need an orthotic.
Yeah. Are you doing those in your office and printing them there, or are they still made by an external lab?
Oh, they're made by an external lab. It's HP, Hewlett Packard, in conjunction with some podiatrists. Yeah. I don't make anything here.
Because there's a future where we're going to have a little printer probably in our office where we're going to print them. The problem is I find right now the final product isn't as, wow, it doesn't amaze you.
I'm not somebody who wants to make stuff, to be honest with you. And I don't like to have a lot of problems. So I'm not somebody who fiddles around with orthotics a whole bunch. It's just not my nature. I like to give them a product that they're going to wear and be happy with, and I don't want it to come back to me 10 times.
Less headaches. Yep.
Yes, exactly.
I agree.
Exactly.
Any other new technology? Do you use any ultrasound or any other types of technology that you use in patient care that you're excited about?
We've been using ultrasound for a long time, and people get the wow factor when you're showing them, their plantar fasciitis. You're showing sub-2 tears and things, or ganglions. That's always a fun one. They like to see that. So we have a diagnostic ultrasound in both of our offices. Other things we're excited about, I think I'm going to be excited about more of the social media that I'm going to learn from you.
We can talk about social media. What's been working for you right now in terms of social media, patient contact, anything that's working right now for you?
I think mostly we have a really nice website, and also works for us as most of the other podiatrists around us don't. And so I think that drives us home a little bit. We have a local magazine in the Merrimack Valley that we've been in and we have a really nice ad that runs in there. But as far as that, we usually just use our website.
Cool. So if people want to learn more about you, Terry, where do they find, what's your website?
WeFixYourFeet.com.
Love that.
So we have that. If they really want to know more about me, they need to come to the golf course.
Good. I'm gonna put that WeFixYourFeet.com. I like that.
Thank you.
Okay. Well, thank you so much for your time, and we're gonna chat again.
I really appreciate you having me. I hope I'm helpful. But thank you very much, and I look forward to seeing you.
Hey guys, thank you for watching Healthy Living. You're going to find a few links here I'd like you to click. One is to subscribe to this channel on YouTube. Also, you can learn more. There are some videos here you can see.